Thank you very much, ma'am, for the kind introduction. Good afternoon, everyone. At the outset, I would like to thank our National President, Dr. Bansi Shabu sir, and also RSSDI for giving me this opportunity to present our data from Kolkata. So my topic was to look at the prevalence of left ventricular diastolic dysfunction and find a correlation with BMI, HbA1c, lipid profile, and microalbuminuria in patients with type 2 diabetes. We went for a retrospective analysis of our EMR data. I do not have any disclosure for this study. Just to give you an introduction as to why we felt that this is an important study, because we know that in patients with type 2 diabetes, risk of heart failure is associated with the status of glycemic control and other cardiometabolic parameters. There are different theories that suggest that hyperglycemia has a role in the development of myocardial dysfunction in diabetic patients, which activates a cascade of pathological remodeling leading to myocardial fibrosis, which is considered to be the main cause of diastolic and systolic dysfunction in the diabetic population. So left ventricular diastolic dysfunction is considered to be the first manifestation of cardiac remodeling in diabetes mellitus, and therefore reinforcing the importance of early examination of ventricular function in individuals with diabetes mellitus. This was the aims and objectives of our study. We wanted to see the prevalence of asymptomatic left ventricular diastolic dysfunction in a population of normotensive type 2 diabetes individuals in the age group of 30 to 60 years. And the reason we chose normotensive population and the age group of 30 to 60 years was because we wanted to remove any confounding factor like hypertension or age, which can separately contribute towards the presence of left ventricular diastolic dysfunction. We also wanted to assess a correlation of the left ventricular diastolic dysfunction with parameters like BMI, A1C, lipid profile, and urine ACR in the study population. This was how we selected the patient. The inclusion criteria included patients in the age group of 30 to 60 years of age, the ones who have been diagnosed with type 2 diabetes, normotensive, and no signs of heart failure, so asymptomatic patients. Our exclusion criteria included patients with valvular or ischemic heart disease, hypertension, atrial fibrillation, heart failure, cardiomyopathy, renal failure, any existent chronic pulmonary disease or thyroid dysfunction, collagen vascular disease, severe anemia, or if there was any history of taking any drug that could affect left ventricular function. Our study design was that it was a retrospective observational study conducted on the EMR-based data, and we screened our entire data of 5 years from October 2016 to September 2021. So the EMR data was analyzed for 12,456 patients. And out of that, we selected only 510 patients based on the inclusion and the exclusion criteria, and we analyzed their data. So this is how the flow of selection went. The EMR was screened for 12,000 odd patients. 9,340 patients with type 2 diabetes were identified, out of which 110 patients had incomplete data, 8,720 patients were excluded based on the exclusion criteria, and finally we came up with the 510 patients. These patients were again grouped into 3 categories: group 1 with normal diastolic dysfunction, normal left ventricular function, group 2 having left ventricular diastolic dysfunction grade 1, and group 3 having left ventricular diastolic dysfunction grade 2. Each of these groups were assessed for the following parameters: BMI, HbA1c, total cholesterol, LDL, HDL, and urine ACR. Now for each of these parameters, prevalence and correlation were assessed for the different grades of left ventricular diastolic dysfunction. In this study population, we included only the grade 1 and grade 2 patients, because the higher grades of left ventricular diastolic dysfunctions would be symptomatic and would also probably not have preserved ejection fraction. So the classification of LVDD, grade 1 is delayed relaxation time, grade 2 pseudonormalization, grade 3 reversible restrictive pattern, and grade 4 irreversible restrictive pattern. The statistical analysis was done. The mean and the SD were calculated for the descriptive statistics of continuous variables. And for continuous variables, the difference of the mean between the groups were assessed by the Kruskal-Wallis test, and also the differences between the independence between the categorical variables was assessed by chi-square and Cochrane-Mantels test. and all the data was analyzed on SPSS. This is our master chart, and if you can look at the second last column, we found statistical significant data in terms of age, weight, BMI, HbA1c, LDL cholesterol, HDL cholesterol, and urine ACR. I'll take you through each of this in the forthcoming slides. Now, first we looked at the age and sex distribution, and that showed that there was a predominance of left ventricular diastolic dysfunction in the 50 to 60 years of age group. When we looked at the sex distribution, we looked at that we found that there was a male preponderance in the study population. Then we assessed the relationship of left ventricular diastolic dysfunction with BMI. This slide shows you the distribution of the BMI in the individual grades of diastolic dysfunction, and we found that there was a higher prevalence of left ventricular diastolic dysfunction in individuals with BMI more than 25. Now, the prevalence of left ventricular diastolic dysfunction showed that increase in BMI shows a significant positive correlation with a p-value of less than 0.001 with the severity of left ventricular diastolic dysfunction. And specifically, if you look at here, you will see that there was a prevalence of the grade 1 left ventricular diastolic dysfunction is proportionately increasing with the increasing BMI. The next assessment we did was the relationship of the LVDD with HbA1c. Again, this distribution study shows that there was a higher prevalence of LVDD in patients with HbA1c greater than 6.5. The prevalence graph, the prevalence study shows that there was increase in HbA1c, shows the significant positive correlation, p-value was 0.01 after analysis with the severity of LVDD. We categorized lipid profile into total cholesterol, LDL, and HDL, and we looked at the total cholesterol first. The distribution was a little skewed here, but at the same time, we found that individual with total cholesterol more than 200 shows a higher prevalence of left ventricular diastolic dysfunction. However, in the prevalence data, we did not find statistical significance when we finalized, but we found that there is a proportionate decrease in the prevalence of normal LV diastolic function with increase in the level of total cholesterol level. Now let's move on to the comparison with LDL cholesterol, and the distribution study showed that individuals with LDL cholesterol of greater than 70 had a higher prevalence of LVDD. Likewise, in the prevalence assessment, we found that individuals with LDL less than 70 were found to have a predominance of normal LV diastolic function. We also saw that increase in LDL cholesterol shows a positive correlation with the severity of left ventricular diastolic dysfunction. When we correlated LVDD with HDL cholesterol level, we found in the distribution section that there is a proportionate increase in the male population with HDL cholesterol less than 35 with increase in the grades of LVDD. We took the cutoff for males as 35, for females we took it as 45. However, the relation of LVDD grades with decrease in HDL cholesterol wasn't significant in proportion in cases of females. The prevalence slide for HDL cholesterol showed that HDL cholesterol below 35 in males and below 45 in females show a higher prevalence of LVDD. Increase in HDL cholesterol showed significant p-value, in this was 0.04. HDL cholesterol shows significant negative correlation with the severity of LVDD. And finally, we assessed the correlation with urine ACR, and we found that there was a higher prevalence of LVDD in individuals with urine ACR more than 30. There is also a proportionate decrease in people with urine ACR less than 30 when we analyze the distribution data with increase in a grade of LVDD. The prevalence data clearly shows here, as you can see by the ones marked with the arrow, that increase in urine ACR shows a significant positive correlation with a p-value of less than 0.001. So finally, we assessed the prevalence of the LVDD in our study population. You can see here normal patients, the individuals with normal LVDD was 216. The ones with grade 1 was 264, and we had 30 patients with grade 2 LVDD. So the prevalence of the left ventricular diastolic dysfunction in the total study population was 58%, out of which we found 52% of them having grade 1 diastolic dysfunction and 6% had grade 2 diastolic dysfunction. So to conclude, left ventricular diastolic dysfunction is highly prevalent in normotensive patients with type 2 diabetes in the age group of 30 to 60 years of age and is positively correlated with obesity, HbA1c, dyslipidemia, and microalbuminuria. A thing to ponder is worsening of glycemic control and other metabolic parameters can therefore be explored as a possible predictor of progression to diastolic heart failure in individuals with asymptomatic LVDD in type 2 diabetes. These are my references, and thank you.